Grammarly helps you work more efficiently, which makes accomplishing your work goals easier than ever before. Get full sentence rewrite suggestions so you can say what you mean faster. Powered by over 1 billion user interactions, Grammarly's instant suggestions help you quickly polish your writing. Use Grammarly to select multiple corrections at once.
Yo, Chad. Yo, Chad, what's going on? Oh, nothing, man. Hey, listen to this.
Is it okay if I'm to say I'm catching feelings from all your dealings? I might stray. What do you say? How are you feeling? Is it the same? I hope you're not planning to waste my time. To my surprise, that was her reply. Now we a vibe. It's been a while and such a ride, the stars align. I love the fact I didn't let her go. She loves the fact that I just let her know. Now we're together, it's a different mode. We getting crazy in a different role. I love the fact I didn't let her go. She loves the fact that I just let her know. Now we're together, it's a different mode. We getting crazy in a different role. We getting crazy in a different.
Walking alone, the streets are empty. The only thing I can see is my own silhouette. I'm getting stronger, step by step. The clock is ticking, but there's no time for me. I've been flying from town to town, from London to Taiwan. I've been all around the globe, trying to protect your soul. We are heroes tonight. We will fly above the sky. town to town, from London to Taiwan. I've been all around the globe trying to protect your soul.
Over the edge, feel like I'm floating through the air. The pain I felt is paid for, all is said and done. Oh, I am restricted, fixed upon the web. I need to kick the habit that my mind is breathing in. Break out, I've got to see. Spent all my life holding all of it closely. I played it innocent, a feel of discontent. I'm finally facing it all, fearless. Burning the bridge that keeps us. I'm here and I'm feeling fearless. Exaggerated, that's what you assume. The story's over now, I must conclude. I am conflicted, watching where I step still, hanging in the balance. Not the life I want to live, I want to take it all. Standing tall, fear outweighed the person you are.
Continue to slow. छोड्दा जस्तो आओस् सुरु गर्नु पर्ला 10 मिनेट अगाडि यस्तै होस् छैन के पढ्ने हो आज 10 अगस्त हो यस टाइम त छैन धेरै के गर्यो यो टाइम रिप्ले पढ्नु त आज धेरै छ यार Oh my god. That's a 659. What a 30 pages. फिर अड़के दोस्त here posterior fetus screen fingers relationship element type and relationship element. मिथाडोन होइन मिथाडोन त्यतिन्छ चाहिँ मिथाडोनले के गर्छ भन्दाखेरि यसमा सघाएको छु मैले मिथाडोन कहाँ छ मिथाडोन opiates peculiarity of methadone by its skin. के पुला यार मेथेडिन त्यसमा चाहिँ नो जिआइजी सिम्टम्स एन्टिमस्कार्डिक हुँदा मिथाडोन भनेको चाहिँ किनकि ओके लङ हाफ लाइफ भएर होला
everybody, and welcome to our first video on teratogens. Teratogens are substances that are dangerous to the baby during pregnancy, and that's because they can cause abnormal fetal development. And common effects of many teratogens include fetal loss. Some of them will simply lead to a miscarriage or a spontaneous abortion. They can also cause growth restriction, birth defects, and impaired neurologic function. There are many mechanisms by which teratogens can harm the baby, and in most cases, the mechanism by which the teratogen works is incompletely understood. I've listed some of the proposed common mechanisms on the screen here. It's unlikely you'll be asked much on the Step 1 exam about the mechanism of teratogen damage to the baby because it's often not known. But what they will want you to know for the Step 1 exam is that the greatest risk is when the fetus is exposed during the first trimester. This is called the embryonic period, and this is when the organs are forming. So exposure to a teratogen during this period can cause an organ to fail to form or to form abnormally. After the embryonic period, the organs are growing in size, and it's less dangerous if the baby is exposed to a teratogen. Even within the first trimester, the effects of a teratogen on the fetus can vary depending on when the fetus is exposed. If the fetus is exposed in the first 2 weeks, this is called the all or none period. In this period, usually the teratogen either causes a spontaneous abortion or it causes no effect on the baby at all. Between weeks 2 to 8, organogenesis is occurring, so this is the time period when exposure to a teratogen can result in a structural defect. And then after 8 weeks, all the organs and limbs are formed, so a teratogen can cause decreased growth. It sometimes causes central nervous system dysfunction, but it usually does not lead to a birth defect if the exposure is after week 8. All the items I've listed on this slide are potential teratogens. In this video, we're going to focus on drugs that a mother may take during pregnancy that can damage the baby. In the second video on teratogen, I'll talk about all these items here. And then finally, I have a separate video on the torch infections, which are dangerous to the baby during pregnancy. So certain drugs are dangerous for mothers to take during pregnancy because they can harm the baby. So how do we know this? It wouldn't be ethical to randomly expose pregnant women to drugs to see what happens to the baby. So the way we determine that drugs are dangerous during pregnancy is first by animal testing. The FDA in the United States requires that all drugs be tested on animal models. Usually this is rodents or rats. Now, even though a drug may appear safe in rodents or rats, sometimes after a drug is brought to market, evidence will appear that it's harmful to the baby. So this appears via case reports. So the second way that we know drugs are dangerous are if case reports begin to appear that women taking a drug have problems with the baby during pregnancy. The FDA labels drugs with a letter to indicate their level of safety in pregnancy. Category A drugs have been shown to have no risk to the fetus even when taken by humans. These are the safest drugs to use in pregnancy. Category B drugs are drugs that have been shown to have no risk to fetus in studies other than human studies, for example, animal studies. Category C drugs are intermediate. In these drugs, risk cannot be ruled out. Category D drugs are drugs where there is positive evidence of risk. And then finally, Category X drugs are absolutely contraindicated in pregnancy. These are drugs that are known to be teratogenic in animals and humans, and the risk clearly outweighs the benefits. The difference between Category X and D is that D drugs are sometimes used in pregnancy in situations where the mother has a very strong indication. Category X drugs are never used in pregnancy. They're absolutely contraindicated. Now let's talk about specific classes of drugs, and I'll begin by discussing the ACE inhibitors and angiotensin receptor blockers, or ARBs. Both of these classes of drugs are used to treat hypertension and heart failure. They both interfere with the renin-angiotensin-aldosterone system. Both classes of drugs are pregnancy class D. In the first trimester, they've been associated with lots of different congenital malformations. They're unlikely to ask you about a specific malformation on the Step 1 exam. But what they want you to know for the Step 1 exam is in the second and third trimester, these drugs can cause oligohydramnios, that is decreased amniotic fluid in the womb. The reason these drug classes can cause this is because they interfere with the renin-angiotensin-aldosterone system, and that can affect the fetal kidneys. So this can lead to decreased fetal kidney function and even fetal renal failure. And it is the urine from the fetal kidneys that creates the amniotic fluid in the womb that serves as a cushion. So if a pregnancy leads to oligohydramnios, that baby can lose its cushioning in the womb, and that can lead to Potter syndrome. I discussed Potter syndrome in the renal video on embryology, but it involves pulmonary hypoplasia and limb and skeletal deformities, all caused by loss of cushioning in the womb due to decreased amniotic fluid, and that is associated with ACE inhibitor or ARB use in the second and third trimesters. All anti-seizure drugs have some teratogenic potential, and this is a big problem for some women in pregnancy because if a woman has epilepsy, she often needs to take anti-seizure medication while she is pregnant because obviously a seizure would be dangerous to her and the baby. All anti-seizure drugs can potentially affect the fetus in a number of ways. One of the most common ways is to lead to a neural tube defect in the baby. But in addition, these drugs have been associated with other problems in the baby like congenital heart disease and cleft palate, short fingers, and abnormal facial features. On this slide, I've listed the 4 seizure drugs with the highest teratogenic potential, and among these 4 drugs, valproic acid in particular is associated with a significantly increased risk of neural tube defects. And if you've watched the neurology video on neuroembryology, in that video I talk about the fact that women often take folic acid during pregnancy because low folic acid levels are also associated with an increased risk of neural tube defects. And it turns out that many anti-seizure drugs are also associated with low levels of folic acid in the mother and the baby. So because folic acid levels when they are low can lead to neural tube defects, and because many seizure drugs lead to neural tube defects, high dose folic acid supplementation is often given to women who have to take a seizure drug during pregnancy. There is a syndrome called the fetal hydantoin syndrome that is associated with phenytoin use in pregnancy. Phenytoin is a version of a chemical substance called a hydantoin, and the syndrome that results when mothers take this in pregnancy is called the fetal hydantoin syndrome. First of all, these babies are born very small, they have growth deficiency, and then they have a number of abnormal facial features. One of the classic ones is a cleft lip and palate. They also have a very small head that's microcephaly, and they also have abnormalities that involve the nose, eyes, and ears. Chemotherapy drugs are highly teratogenic during pregnancy. This should make sense to you. These drugs target rapidly dividing cells with the goal of killing cancer cells, but if they're given to a mother who is pregnant, they can target the rapidly dividing cells in the baby. Unfortunately, in some rare circumstances, women develop malignancy when they're pregnant. In particular, Hodgkin lymphoma sometimes occurs among women who are pregnant. Now, ideally, if the cancer is of a low grade, you can defer chemotherapy until after birth, or at least until the 2nd or 3rd trimester when the baby is out of that embryonic period. If chemotherapy has to be given in the 1st trimester, fetal malformations are very common, about 15% when born to women who receive chemotherapy in the 1st trimester. The highest risk agents in pregnancy are the alkylating agents and antimetabolites. I talk about both of these drug classes in the hematology videos on chemotherapy, but both of these drug classes disrupt DNA function, so you can imagine how damaging that can be to the fetus growing in the womb. They have a number of adverse effects on the fetus that have been described. First of all, they can lead to a spontaneous abortion, but a classic effect of these drugs is missing digits in the fetus. This is a picture of that on the screen to help you remember it. In addition, though, they've been associated with lots of other fetal anomalies. Isotretinoin is a derivative of vitamin A, and it's used to treat acne. It is pregnancy class X. Women who become pregnant while taking this drug have a 20% risk of having a miscarriage or spontaneous abortion. Among women who do carry their baby to term, embryopathy is present in 20 to 30% of the live births. This includes abnormal facial features like low ears and wide-spaced eyes, also congenital heart disease and hydrocephalus. So the key point here is that women who are taking this for acne must take birth control, and this is a big issue because women who take this drug are often teenagers or young women who are sexually active, and they need to understand that there are severe consequences if they become pregnant when they're on this drug. So primary care doctors and dermatologists who prescribe isotretinoin often prescribe birth control at the same time to women who wish to take this drug to improve their acne. And just like isotretinoin, a vitamin A derivative, is teratogenic, vitamin A, when taken in excess dosages during pregnancy, is also teratogenic. Women who take very high dosages of vitamin A in the 1st trimester can cause harm to the baby. Often this can lead to a spontaneous abortion, but it can also cause microcephaly and cardiac anomalies, very similar to the problems that occur in women who take isotretinoin when they're pregnant. Now, in order for this to happen, women have to take vitamin A at dosages several times the recommended daily allowance. So this really only happens in women who take mega dosages of vitamin A. Methotrexate is a drug that inhibits folate metabolism. It has a chemical structure very similar to folate, as shown at the bottom of the screen. It's used as an anti-inflammatory in many autoimmune conditions. It's also sometimes used as an anti-cancer drug. Methotrexate is pregnancy class X. In fact, it's used to induce abortion in ectopic pregnancies. And if you know that, it's an easy way to remember how dangerous this drug can be to the baby. If mothers take this drug during pregnancy and they do not have a spontaneous abortion, the baby is often born with neural tube defects, and that's easy to remember if you know that low folate levels are associated with neural tube defects, and this drug works as an anti-folate drug. And decades ago, when methotrexate or another anti-folate drug called aminopterin were given during pregnancy, this resulted in babies that were born with a characteristic embryopathy. This included neural tube defects, but also a number of other abnormalities like abnormal skull and face shape and cleft palate and hydrocephalus and limb anomalies. And so because all of these things can happen if mothers take methotrexate during pregnancy, it is no longer administered during pregnancy. Warfarin is an anticoagulant that I discuss in videos in the
Where's your mouse mirror? Light radio, this is light. You can call me whatever you want, call me first. ठीक है
hematology section. It is pregnancy class D. Through its blood thinning effects, it can lead to fetal hemorrhage, which can cause a spontaneous abortion. It's also been associated with vision problems via optic atrophy in the baby. And then finally, women who take this drug during pregnancy have babies that are born with a characteristic warfarin embryopathy. This includes a number of bone and cartilage abnormalities. One of the classic findings on X-ray is the presence of stippled epiphyses. These are small, round densities on X-rays seen in the bones. If you look at this X-ray here, you can see all these white dots near the top and bottom of the two bones shown in the image. Those are stippled epiphyses, a classic finding of warfarin embryopathy. Other findings also involve the bone and cartilage. These are things like nasal hypoplasia and limb hypoplasia. Methimazole is a drug used to treat hyperthyroidism. It is pregnant.
कतिजना भ्यू छ
छैन
कोही पनि छैन
त्यतिको अब
जतिखेर उयो गर्छ स्ट्रिम
नै अहिले चाहिँ यस
मजा
यो नेट राम्रो काम गरिरहेछ हैन यस अब नि मैले के रे केबल के इथरनेट केबल के मैले अहिले लिन जान्छु
यहाँ तिमी अर्कै चीज गर्दैछौ त ढिलो भएको है
अनि यो ल्याग हो ल्याग हो
कति सेकेन्डमा एक मिनेट अगाडि
मैले कार्ड यो 37 भयो तपाईले कति छ सो त्यो यो 20 सेकेन्डको ल्याग छ तिम्रो यहाँ
पढिरहेछ नि कत्रो पढेन लाग्छ नि पढ्नु पढिरहेछ
अनि आज के रे बिहानै फोन गरेको त्यो वर्लिङले
के भन्ने
त्यो नेट कस्तो छ हिजो मैले फोन गरेर उदा के रे
वर्लिङले कल गरेर सोधेको नेट कस्तो छ भनेर
हैन हैन वर्लिङलाई हिजो मैले गरिरहेको थिएँ
के त्यहाँ राखेको
आइता राखेको कमेन्ट गरेको त्यो पछि अरे वर्लिङले फोन गरेर बिहान 4 उठेन निन्दा लागेन अनि के गर्नु
अनलाइन जब भयो भने यही राखेको क्लियर देखिन्छ नि
pregnancy class D. First of all, it can disrupt thyroid function in the baby.
सर्टिफिकेट लेख्यो आमा लेख्यो अब फेरि आज राति गर्नुपर्छ यो कस्तो आउँछ नि
आज अन्तिम छ
पर्दाले ल्याङ गर्यो त You can call me whatever
This
you
can lead to
want.
fetal and neonatal hypothyroidism. In addition, it's associated with a number of fetal anomalies. The classic one is aplasia cutis. This is absence of a patch of epidermis on the scalp. Usually it's a solitary defect of the scalp in about 70% of cases. And in a board question, they will describe a baby born with a missing patch of skin or hair. When you hear that description, you should think that the mother may have taken methimazole. Now, methimazole is a very effective drug for hyperthyroidism in pregnancy, so it's sometimes used in the second or third trimester once the baby is out of that embryonic period. But in the first trimester, it is not used, and the drug of choice in the first trimester is propylthiouracil. It's a related drug that's slightly less effective, but it's safe in that embryonic period. Lithium is used in psychiatric disorders. It's pregnancy class D. Its teratogenic effects primarily involve the heart, and the classic congenital anomaly in a baby born to a mother who took lithium when she was pregnant is Epstein's anomaly of the tricuspid valve. This is a drawing of it shown on the screen here. In Epstein's anomaly, the tricuspid valve is displaced toward the apex of the right ventricle, and I discussed this in more detail in the cardiology videos on congenital heart disease. There are a number of antibiotics that are dangerous in pregnancy. I'll highlight just a few of them in this video. The aminoglycosides can cause permanent deafness in the fetus, just like they can cause ototoxicity in adults. Tetracyclines accumulate in the fetal teeth and long bones, and they can lead to permanent discoloration of the fetal teeth. And the fluoroquinolones can cause fetal cartilage damage, and therefore they are not used in pregnancy. Trimethoprim is a drug that disrupts folate metabolism in bacteria, but it can also disrupt folate metabolism in the fetus. And just like we've talked about before, when babies have low folate levels, this can lead to neural tube defects. And then finally, the sulfonamides can displace bilirubin from albumin. This can lead to kernicterus, which is permanent brain damage from high bilirubin levels when babies are exposed to high bilirubin levels after birth. I'll finish this video with two drugs that really aren't used much anymore in the modern era. They're largely of historical significance. The first one is thalidomide. Thalidomide is a drug that is pregnancy class X. It is rarely used in the modern era to treat multiple myeloma. However, in the 1950s, it was commonly given to pregnant women as a sedative, and their children were born with numerous limb deformities. They had amelia, which is absence of a limb, or micromelia, which is short limbs, or sometimes they had phocomelia, which is abnormal limbs. This is a picture of a baby born to a mother who took thalidomide, and these children born with these defects were called the children of thalidomide. They were all born in the 1950s. And if you like rock and roll and listen to Billy Joel, he has a song called We Didn't Start the Fire, and in that song he sings about the children of thalidomide. He is referring to the children of mothers who took this drug. Diethylstilbestrol is a non-steroidal estrogen. This is its structure shown on the screen here. It functions like an estrogen, but it does not have a 4-ring chemical structure. And decades ago, it was used to prevent miscarriage and premature birth in pregnant women. However, it was removed from the U.S. market in 1971. The reason it was removed from the market is because, first of all, there was a slightly increased risk of breast cancer for the mothers who took this drug. But more importantly, the female babies of mothers who took this drug had numerous reproductive tract abnormalities. So girl babies born to mothers who took DES during pregnancy often have a small or hypoplastic uterus. They also often have a small or hypoplastic cervix. In addition, they have what's known as vaginal adenosis. These are little nodules on the wall of the vagina. They're caused because of epithelium from the cervix or endometrium that develops in the vagina. This is metaplasia of the endothelium in the vagina so that it becomes more like cervical or endometrial epithelium. And when you look at a biopsy specimen of vaginal adenosis, what you see is endothelium that looks like it came from the cervix or endometrium, but it's found in the vaginal wall. This is believed to be caused by persistent Müllerian tissue in the vaginal wall after birth. And then finally, these girl babies born to mothers who took DES are at increased risk for vaginal clear cell carcinoma. So remember that this drug was taken off the market in 1971. So the girl babies born to mothers who took this drug are now in their 40s, 50s, and 60s. And many of them are followed closely by their gynecologists because those women are at increased risk of this malignancy because their mother took DES when she was pregnant. In addition, as you can imagine, because these women often have a small uterus and cervix, there's a high rate of infertility among women who were born to mothers who took this drug. And that concludes our first video on teratogens. Hi everybody, and welcome to our second module on teratogens. All the items listed on this slide are potential teratogens. In the first teratogen video, I talked about drugs. In this video, we're going to focus on these items here, highlighted in red. And in a separate video, I talk about the torch infections that are dangerous during pregnancy. Let's start by talking about alcohol. If mothers who are pregnant consume large amounts of alcohol, this can potentially harm the baby. One of the main ways by which alcohol harms the baby is that it acts as a neurotoxin. There are multiple mechanisms of this effect. Alcohol can lead to cell death, failure of nerve cell migration, but through all of these effects, alcohol often damages the central nervous system of the baby, and therefore one of the main outcomes from mothers who drink during pregnancy is that their babies are born with intellectual disability, which is also known as mental retardation. Now, in some cases, in addition to intellectual disability, the baby is born with other features of a syndrome called the fetal alcohol syndrome. So the fetal alcohol syndrome is intellectual disability from alcohol plus characteristic facial features and congenital heart defects and skeletal anomalies. So this is a picture of the classic appearance of a baby with the fetal alcohol syndrome, and there are three key findings. First of all, there is a smooth philtrum. So the philtrum is the groove from the base of the nose to the upper lip, shown here in the picture, and this is smooth in babies who have the fetal alcohol syndrome. Notice that it looks like there almost isn't a philtrum in this baby on the screen. In addition, these babies have short palpebral fissures. The palpebral fissures are the openings of the eyes, and these babies have a small opening of the eyes. And then finally, there's a thin vermilion border. The vermilion border is the upper lip, and the upper lip in this baby on the screen you can see is very thin and narrow. These babies also often have congenital heart defects. There are lots of different defects that can occur in children born to mothers who drink alcohol, but some of them are listed on the screen here. These include atrial septal defects, ventricular septal defects, and even tetralogy of Fallot. In terms of growth and skeletal abnormalities, basically these babies are just very small. If you notice that picture I showed 2 slides ago, the baby's head was very small, and babies born to mothers who drink are very small in general, and they often remain below average for height and weight throughout their lives. Sometimes these babies also have limb defects, so their fingers can be contracted, and sometimes they have congenital hip dislocations as well. Finally, let's talk about the central nervous system effects of alcohol. First of all, babies born to mothers who consume alcohol when they're pregnant can have structural defects of the brain. Basically, the brain is just smaller than it should be in these babies. That's an easy way to remember this. Basically, everything about these babies is just small. So these babies often have a small head, which is microcephaly, and they can have small other structures in the brain, like the corpus callosum, the cerebellum, and the basal ganglia. In the most severe form, these babies can be born with holoprosencephaly, where they have a single lobe of the brain. In addition, these babies often have abnormal reflexes, which can be detected at birth. They can also have hypotonia and cranial nerve deficits, and that can also be detected at birth. And then, as I said before, one of the major problems when mothers drink during pregnancy is that their children will have lifelong intellectual impairment with a reduced IQ. I'll finish our discussion of alcohol with this slide and talk about the timing of exposure. Babies that are exposed to alcohol in the first trimester are the babies that tend to develop the facial abnormalities, the brain abnormalities, and congenital heart disease. On the other hand, exposure to a teratogen like alcohol in the third trimester mostly affects growth, because in the third trimester, the body has formed, the baby is just growing in size. So alcohol exposure in the third trimester mostly affects the size of the baby and the growth of the brain. And then finally, I just want to mention that intellectual impairment or mental retardation cooperation can occur in absence of the facial or brain anomalies. Remember that intellectual impairment is one of the major consequences of pregnancy-associated alcohol consumption. So just because a baby's born and doesn't appear to have any birth defects, it doesn't necessarily mean that that baby won't later in life show evidence of intellectual impairment. Now let's talk about smoking during pregnancy. There are two toxins in cigarette smoke that can harm the baby. First of all, there is nicotine, and secondly, there is carbon monoxide. Both of these substances can impair oxygen delivery to the fetus. This is what you want to know for step one of your boards. First of all, nicotine can cause vasoconstriction, and this can decrease placental blood flow. And then carbon monoxide can compete with oxygen for binding to hemoglobin, and this can decrease the amount of oxyhemoglobin in the maternal blood. So by both of these mechanisms, less oxygen is delivered to the fetus during pregnancy. And if you understand that mechanism, it's very easy to understand the consequences of smoking during pregnancy. First of all, the baby will not grow enough. Intrauterine growth restriction and low birth weight are common among children born to women who smoke. In fact, 20% of cases of low birth weight babies are associated with smoking. In addition, because there's poor oxygen delivery to the placenta,
no data रे के भयो नेट लस इट आयो ब्याक फेरि नेट स्लो भयो यार किन यार
abnormal placental abruption, placenta previa, and premature rupture of membranes are all more common among women who smoke during pregnancy. Preterm labor is also more common among women who smoke during pregnancy. And then finally, there's a well-documented association with sudden infant death syndrome and mothers who smoke during pregnancy. SIDS is when babies die during their first year of life, often in previa and premature rupture of membranes are all more common among women who smoke during pregnancy.
Previa, placenta previa. Kasa dost, kasa. Tin 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 tin. Pathology. Eta attach गर्छ इन पेनिट्रेट गर्छ पर्फोरेट कस्तो चलेको नेट यार
Preterm labor is also more common among women who smoke during pregnancy. And then finally, there's a well-documented association with sudden infant death syndrome and mothers who smoke during pregnancy. SIDS is when babies die during their first year of life, often in their sleep, and there's a well-documented association of this with smoking during pregnancy. Using cocaine is also dangerous to the baby during pregnancy. Just like nicotine, cocaine causes vasoconstriction, and therefore the effects of cocaine on pregnancy are similar to those of smoking. Babies born to mothers who use cocaine are often small with low birth weight, and there's an increased risk of placental abruption, preterm birth, and even miscarriage. Mercury is a potential teratogen. Mercury is a metallic element. This is a picture of liquid mercury on the screen here, and it's found in abruption, preterm birth, and even miscarriage. Mercury is a potential teratogen. Mercury is a metallic picture of liquid mercury on the screen here, and it's found in fish and seafood in the form of methyl mercury. Methyl mercury is mercury bound to a methyl group. This is found in fish and seafood, and it's not removed by cooking, and the highest levels are found in swordfish, shark, tilefish, and mackerel king. This is a picture of a mackerel king at the bottom of the screen here. And it turns out that the fetal brain is highly sensitive to mercury. The mother is usually not affected. So if a mother eats lots of these type of fish during pregnancy, the baby can potentially be harmed. This often results in developmental problems where the child grows up with delayed milestones. Rarely it can cause severe problems like blindness, deafness, or cerebral palsy. So women who are pregnant often try to avoid eating fish for the fear that some types of fish contain mercury. X-rays are another potential teratogen. This is somewhat controversial because there is no evidence of harm at small doses, and the threshold for harm, meaning the amount of X-rays it takes to harm the baby, has not been definitively determined. Most sources agree that higher dosages at 8 to 15 weeks can potentially cause intellectual disability, microcephaly, or growth restriction. Most of these data are based on women who were pregnant and survived the atomic bombs in World War II. Based on those data, we think that high dosages of X-rays are harmful at this period of time. And because of this, lead shielding is usually used to protect the fetus if the mother requires exposure to X-rays. So for example, if a mother has a respiratory infection and needs to have an X-ray of her chest, a lead shield, like what this man is wearing here, will be placed over her belly, and X-rays cannot penetrate lead shielding, and therefore the baby will not be in any danger. Now let's talk about problems among babies when the mother has diabetes. There are multiple effects of maternal diabetes on the baby. First of all, this can lead to increased growth. Remember that glucose is fuel for growth of the fetus, so if the mother has diabetes placed over her belly, milestone, World War II, and effects of maternal diabetes on the baby. First of all, this can lead to increased growth. Remember that glucose is fuel for growth of the fetus, so if the mother has diabetes and her blood sugar levels run high, the baby can get very large. In addition, the baby can have blood sugar alteration problems with high or low blood sugar. In addition, there's a higher risk of congenital heart disease and CNS disorders. And all of these adverse effects are related to the severity of the diabetes. So if the mother keeps her blood sugar well controlled during pregnancy, these effects are very unlikely. Mothers who poorly control their blood sugar have a much higher risk of abnormalities in the baby. So the first potential effect of maternal diabetes is macrosomia, which basically means a large baby. Children born to diabetic mothers are often large for gestational age. Their weight is often greater than the 90th percentile, and these babies are often greater than 9 pounds at birth. Usual weight for a baby at birth is about 6 or 7 to 8 pounds. 9 pounds or greater than 10 pounds is an enormous baby, like this child shown on the screen here. And because these babies are so large, this can potentially lead to birth injury during delivery. Sometimes the babies suffer what is known as shoulder dystocia. This is where the shoulders cannot pass through the birth canal. It can be difficult to get the baby out, and sometimes an emergency section is required. Another problem that occurs among babies born to diabetic mothers is neonatal hypoglycemia. So in the womb, if the fetus is exposed to high levels of blood sugar from the mother, the baby will begin making lots of insulin. This is called a hyperinsulinemic state. After birth, however, the baby no longer needs all that insulin, but it's still circulating and being generated. So in the first 20 24 hours or so of life, blood glucose levels can get low, sometimes below 40, which can potentially cause a seizure. Now, this is transient. It usually resolves after about 24 hours, and because of this reason, if the mom is diabetic, the baby needs close glucose monitoring after delivery. Congenital heart defects occur in 3 to 9% of babies born to diabetic mothers. There lots of different heart defects that have been described, but the classic one you should remember for step 1 of your boards is transposition of the great arteries. This is associated with maternal diabetes. In addition, all of these other defects I've written on the screen here can potentially occur. There is a congenital anomaly called the caudal regression syndrome. It's also called sacral agenesis. This is a rare congenital abnormality, but it's much more common among children born to maternal diabetics. It's classically associated with maternal diabetes. Usually it occurs in children of insulin-dependent mothers. In this syndrome, there is incomplete development of the sacrum. This can lead to what's known as sirenomelia, which is the mermaid syndrome, where children are born with fusion of the legs. In addition, they can be missing the bones of the sacrum, and it also includes a neural tube defect in many cases. So you can basically think of that lower pelvic region as being entirely abnormal. So the sacral bones are missing, there may be a neural tube defect, and the legs are fused together. On the left side of the screen is a baby with sirenomelia. You can see that the legs are fused together. On the right side of the screen is an x-ray of a child with sacral agenesis. You can see that the bones in the bottom of the pelvis are very, very small. This is because they have not grown normally. The last topic for this video is phenylketonuria. Patients with phenylketonuria cannot metabolize the amino acid phenylalanine. I talk about this disorder in detail in the biochemistry video on phenylalanine. But for our purposes here, you should know that if a mother has phenylketonuria, her baby is at risk, because if she consumes phenylalanine, she cannot metabolize it, and high levels of phenylalanine act as a teratogen. So during pregnancy, women who have PKU have their phenylalanine level monitored, and it needs to be kept normal, and dietary restriction of phenylalanine is essential during pregnancy so that the levels don't build up and harm the baby. You can think of the effects of phenylalanine on the baby as similar to those of alcohol. That's an easy way to remember them. So babies born to mothers with PKU can be small, they can have intrauterine growth restriction, they can have microcephaly, they often have intellectual disability or mental retardation, and in addition they often also have congenital heart defects. One of the common congenital heart defects in babies born to mothers with PKU is coarctation of the aorta. They also often have a rare congenital heart syndrome called hypoplastic left heart syndrome. And that concludes our second video on teratogens. Hello everyone, and welcome to our module on genital embryology. In this video, we're going to talk about the development of the genital system. So first of all, you should be aware that the chromosomal sex of a fetus is determined at fertilization. A fetus with 2 X chromosomes is female, and a fetus with an X and Y chromosome is male. Now later, the fetus will develop gonads, which are the ovaries and testes, and internal and external genitalia. And if the baby develops normally, the gonads and genitalia will match the chromosomal sex. In this video, we're going to talk about how the genital system develops, and I strongly recommend to you that you think about development of the gonads separately from the internal genitalia, and the internal genitalia separate from the external genitalia. Basically, all 3 of these elements of the genital system have their own developmental processes, and we're going to go through them one at a time in this video. We'll start by talking about the development of the gonads. There are structures in the embryo called gonad bridges that form at about 7 They are derived from mesenchyme, which is embryonic connective tissue made up mostly of mesoderm. The germ cells, which will eventually develop into sperms and eggs, are derived from epiblast cells. The epiblast is one of the 2 layers of the bilaminar disc in early embryo development. These germ cells will invade the gonadal ridges, and if they don't reach the ridges, the gonads will never develop. So a key element is that germ cells which come from the epiblast have to migrate and invade the gonadal ridges. And initially, the male and female gonads in the embryo are identical. This is called the indifferent gonad. It is not yet a testis or an ovary. If the fetus has a Y chromosome,
It is, my God. 2000, 400, 200 it is. 4,010 rupees kind of. 200 is like that. This 200.
then it will have the SRY gene, which is found on the Y chromosome. And this gene on the Y chromosome is what makes male babies male. It codes for the testis determining factor, which leads to the formation of Sertoli and Leydig cells. Once these cells form, the Leydig cells begin producing testosterone, and testosterone leads to male development. There are structures called medullary or testis cords, which will begin to form once testosterone is present, and they will expand out of the testis and connect to the genital ducts, which we'll talk about later. So the key point here is that you must have the SRY gene on the Y chromosome to form testes. If you do not have this gene, then ovaries will form. Talk about later. So the key point here is that you must have the SRY gene on the Y chromosome to form regress. A different type of cords called cortical cords will develop. They will form clusters in the gonad and surround the germ cells, and then the oogonia and follicular cells will form into primordial follicles inside of the ovary. So now we've talked about how the developing embryo begins with two indifferent gonads, and if the embryo has a Y chromosome and the SRY gene, then testes will develop. If the embryo does not have a Y chromosome, then ovaries will develop. Now we have to talk about how we develop the internal genitalia that hook up to these gonads. Are we going to develop an epididymis and a vas deferens like in the male, or are we going to develop fallopian tubes like in the females? Like the vas deferens and the fallopian tubes develop from what's known as the genital ducts. These are two pairs of structures called the genital ducts that are found in the embryo. The duct that can develop into male structures is called the mesonephric or Wolffian duct, and the duct that can develop into female structures is called the paramesonephric or Mullerian duct. And basically what's going to happen is one of these ducts is going to persist and the other one is going to go away depending on whether the child develops into a male or female. And just an aside here, in the renal video on renal embryology, I talked about the mesonephros. This is the interim kidney in the first trimester. It eventually goes away and does not persist into the adult. However, it has an associated duct called the mesonephric duct, and that's where this duct gets its name. It also has another duct that is near the mesonephric duct, and that is called the paramesonephric duct, which is how the Mullerian duct gets its name. So as I mentioned before, the two genital ducts will develop into the internal genital tracts. In the male, they will form the epididymis, the vas deferens, and the seminal vesicles. In the female, they will form the fallopian tubes and the uterus and the upper vagina. So let's talk acts. In the male, they will form the epididymis, the vas deferens, and the seminal vesicles. In the female, they will form the fallopian tubes and the uterus and the upper vagina. So let's talk about how the genital ducts develop in the male. Obviously in the male, you want the Mullerian ducts to go away because those lead to development of female structures. The way this happens is the Sertoli cells release a substance called Mullerian inhibitory factor. It suppresses development of the paramesonephric or Mullerian ducts, and they will eventually go away, but for a small remnant in the male called the appendix testis. This is a little bit of tissue at the upper testis. It's shown here in this drawing at the bottom right side of the screen. In addition, in the male, the Leydig cells will secrete androgens, and these will drive development of the mesonephric ducts into male structures. And in the male, the mesonephric duct will elongate to form several key internal structures. These include the epididymis, the ductus deferens, the seminal vesicles, and the ejaculatory ducts. And here in this drawing at the bottom of the screen, it transports sperm from the seminiferous tubule, this larger duct, and comes from the seminal vesicles. They connect with the ejaculatory ducts so that semen comes from the prostate, and that connects to right here, bladder, and all. Now, the paramesonephric ducts will form the internal female structures. This develop, like the Mullerian duct, is a structure that is a remnant of the Wolffian or mesonephric duct that persists in females. They're found on the vaginal walls. Sometimes they form. Cyst, which can occasionally become painful and require surgical removal. And here's a picture to just kind of pull it all together. So the embryo begins with a bipotential gonad, and both the Wolffian and Mullerian ducts are present. If the SRY gene is present in the embryo, then testosterone will be synthesized, and Mullerian inhibitory factor, sometimes called Mullerian inhibitory substance, is also secreted. This will drive formation of all the male structures. If these two factors are missing, in other words, if the baby is female and there's no testosterone genitalia derived from another embryologic structure called the urogenital sinus. In the embryo, there is a structure called the cloaca, which is part of the gut tube. I'll show you a picture of this in a minute. And it divides and forms the urogenital sinus and the anal canal. And the urogenital sinus goes on to develop into some of the male and female internal structures. Here's a drawing I used to discuss the formation of the gut in the GI video on GI embryology. And I just want to point out that the cloaca is this turn in the gut tube down here at the bottom. It will connect to the exterior of the embryo and form a hole. It will then divide down the middle. The bottom portion will become the anus, which connects to the GI tract. The top portion will be a blind-ended cavity. That's called a sinus, and that will be called the urogenital sinus, which will give rise to some of the internal genitalia. It will also persist as a hole on the outside, and that portion of the urogenital sinus will give rise to some of the external genitalia, which we'll talk about later. In males, the upper portion of the urogenital sinus forms the bladder. The pelvic or middle portion forms the prostate and the prostatic urethra, and then there's another portion called the phallic portion, which forms the penile urethra. In females, the upper portion of the urogenital sinus also forms the bladder, so you can just remember that the bladder always comes from the urogenital sinus, no matter whether it's a male or female child. The pelvic portion of the urogenital sinus in females, however, forms the inferior vagina and connects with the paramesonephric or Mullerian ducts. So in females, the inferior vagina comes from the urogenital sinus, and the superior vagina comes from the Mullerian ducts. One of key structures that derives from the Mullerian ducts in females is the uterus, and in order for the uterus to form, both the left and the right Mullerian duct must come together normally and fuse to form the uterus in the middle. Many times this process doesn't happen normally, and this leads to anomalies in uterine development. So-called lateral fusion defects are the most common type.
Okay, break it. I'll come in 20 minutes. Okay. हेलो 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 पाइरहेको थिएँ यार म भर्खर म त केबल लिन गएको पसलले बन्द रहेछ वेट अझै 2-3 मिनट पर्खौँ यार Right. Moving more. To go in that.
Of uterine anomaly. This is when the two sides of the uterus don't come together normally, because remember, the uterus has to come from both Mullerian ducts coming together normally. And the problem this can create for women is infertility and pregnancy loss. If the uterus doesn't have a normal shape, it can be difficult for the embryo to implant in the wall of the uterus. The most common uterine anomaly is called a septate uterus. It gets its name because in this condition there's a septum that divides the uterus into two endometrial cavities. Basically, a normal uterus is supposed to look something like this with a cavity in the middle. In a septate uterus, what you have is a septum dividing the uterus into two cavities like this. This occurs because this septum in the middle is supposed to be resorbed during development. It's a remnant of the two Mullerian ducts, and if it's not resorbed, it leaves this septum down the middle. And this
ब्रेक में चल रहा है आज खाना खाने टाइम पनि भयो हैन 10 minutes let's go boom bam
can potentially be treated with a surgery called septoplasty, where they cut out the septum. And then there are a number of other less common uterine anomalies. In a bicornuate uterus, the fundus is indented due to partial fusion of the Mullerian ducts. Basically, in this condition, the uterus looks something like this, with one pathway going over here to one fallopian tube and another pathway going over here to another fallopian tube. It's not that there's a septum down the middle like we talked about in a septate uterus, it's that the uterus itself is indented. In a unicornuate uterus, the uterus connects only to one ovary and the other ovary is not connected to the uterus at all. And then finally, there's a condition called uterine didelphys, or double uterus, where the Mullerian ducts fail to fuse whatsoever, and there are basically two separate uterus structures. So there's one on one side that goes over to one fallopian tube, another on the other side, and they're not connected at all by any tissue in the middle. And the way these conditions are usually diagnosed is by what's known as hysterosalpingography. This is where you inject dye into the uterus and you see the shape of the uterine cavity. That's what's shown here on the screen. So now we've talked about the gonads and we've talked about the internal genitalia. All that remains is to discuss the development of the external genitalia. And just like the gonads, the external genitalia begin with an indifferent stage where they look the same, whether it's a male or female baby. In this indifferent stage, there are four key structures that will develop into the external genitalia. First of all, there is an opening called the urogenital sinus. We talked about this before. This is the opening to that sinus that comes from the cloaca when it divides to form the anus, which will be somewhere down here, and another opening up above, which is the urogenital sinus. Around the urogenital sinus, there are folds of tissue called the urogenital cavity. That's what's shown here on the screen. You begin with an indifferent stage where they look the same, whether it's a male or female baby. In this indifferent stage, there are four key structures that will develop into the external genitalia. First of all, there is an opening called the urogenital sinus. We talked about this before. This is the opening to that sinus that comes from the cloaca when it divides to form the anus, which will be somewhere down here, and another opening up above, which is the urogenital sinus.
Yes.
Around the urogenital sinus, there are folds of tissue called the urogenital folds that also come from the cloaca. Above the sinus, there's a small nodule of tissue which is called the genital tubercle, and then surrounding the urogenital folds, there are swellings called labiosacral or genital swellings. Basically, what's going to happen is in the male, the genital tubercle is going to elongate into the penis, and the urogenital sinus is going to close. In the female, the urogenital sinus is going to remain as the opening to the vagina, and the genital tubercle will become the clitoris. So here's what happens in the male. The genital tubercle elongates and forms the phallus, which is just another word for penis. Those folds of tissue called the urogenital folds will close and form the penile urethra. And then the urogenital sinus will go on to form glands. Remember that sinus is a cavity that goes inside the embryo. The opening to the cavity will be closed when the folds come together and form the penile urethra. But that cavity that goes inside of the embryo will form glands inside the embryo. And in the male, this includes the prostate and also the bulbourethral glands of Cowper, which both contribute some of the fluid to ejaculate. And then finally, those labial sacral swellings, which are those swellings of tissue on the outside of the indifferent gonad, will ultimately go on to form the scrotum. In the male, the urethral folds, which are located on the outside of that opening, the urogenital sinus, have to come together and seal in order to form the underside of the penis. If they don't come together normally, an opening can be left, and this is called hypospadia. This is a congenital anomaly of the male urethra. It's a ventral opening of the urethra, meaning an opening of the urethra on the underside of the penis. It's caused by failure of the urethral folds to completely close. And these are some examples of hypospadia at the bottom of the screen here. And in about 10% of cases, when a male child is born with hypospadia, there is also cryptorchidism, which is failure of the testes to descend normally into the scrotum. In contrast, an epispadia is a urethral opening on the dorsal side of the penis. This is much less common than a hypospadia. Remember, those urogenital folds have to come together kind of like a zipper, and it's very easy for a little gap to remain and cause a hypospadia. In contrast, for an epispadia to form, the only way this can happen is if there is abnormal position or formation of the genital tubercle, and this is much less common. And because the genital tubercle is at the top of the external genitalia close to the bladder, this commonly occurs together with bladder extravasum for a little gap. It's caused by failure of the urethral folds, which is failure of the testes to descend normally into the scrotum. In contrast, an epispadia is a urethral opening on the dorsal side of the penis. This is much less common than a hypospadia. Remember, those urogenital folds have to come together kind of like a zipper, and it's very easy for a little gap to remain and cause a hypospadia. In contrast, than a hypospadia. Remember, those urogenital folds have to come together kind of zipper, and it's very easy for a little gap to remain and cause a hypospadia. In contrast, for an epispadia to form, the only way this can happen is if there is abnormal position or formation of the genital tubercle, and this is much less common. And because the genital tubercle is at the top of the external genitalia, close to the bladder, this commonly occurs together with bladder exstrophy, where the bladder is located outside of the body. Development of the external genitalia in the male requires dihydrotestosterone. Recall that testosterone can be converted to dihydrotestosterone by the enzyme 5-alpha reductase, and dihydrotestosterone is a much more potent androgen than testosterone. So rarely, male children are born with a 5-alpha reductase deficiency, and as a result, they will have ambiguous genitalia until puberty. That's because there's not enough dihydrotestosterone around to drive formation of the male external genitalia in development. At puberty, there's usually a rise in testosterone levels, and they may be able to create enough dihydrotestosterone to drive formation of male external genitalia, but at birth, they have ambiguous genitalia because they can't form dihydrotestosterone. Now let's talk about external genitalia development in the female. So in the female, the genital tubercle elongates and becomes the clitoris. In the female, the urogenital folds do not fuse, they persist and become the labia minora. In females, the urogenital sinus forms glands, just like in the male, but different glands form the female. In the female, glands called paraurethral glands of Skene form. These are the female analog to the prostate glands. In addition, the urogenital sinus forms glands called the Bartholin glands. Both of these glands lubricate the vagina. And then in females, the labiosacral swelling develops into the labia majora, not the scrotum. And for this process levels.
Excellent. Vesicle भनेको ब्ल्याडरतिर, पोस्चर भनेको इन्टेस्टाइनतिर. गरिनु फेरि भन्दा पनि यो त्यो पजलमा एक्युट निमेटोड त्यसको होला Endometrium acute endometrium chronic हो acute त डेलिभरी को प्रेग्नेन्सी I'm interested in चाहिँ के फरक भयो के फरक भयो भन्दाखेरि चाहिँ म भन्छु युरोथेरापी पार्टहरू के हुन्छ यो पेनाइल युरेथ्रा र बल्बस युरेथ्रा मेम्ब्रेनस प्रोस्टेटिक एउटै हो मेम्ब्रेनस प्रोस्टेटिक उतापट्टि छ युरेथ्रा बन्जिस पेपेसेटमा हुन्छ बल्ब मेम्ब्रेनस टिपमा हुन्छ प्रोस्टेटिक यतापट्टि हो मेम्ब्रेनस अनि बल्ब नाइस एउटा खिच्दिउँ अब गीत बजाएर छोडिदिन्छु ल I'll come in 15 minutes. You just chill down. कपिराइटको मात्र बजोस् फेरि अरू बज्यो भने त कहाँ हुन्छ त फेरि यसको प्लिज भइहाल्छु ल कतिवटा गीत छ 11वटा गीत 11वटा गीत
One's a company, two's a cropper, three's a party coming, move around like fresh when the school is out, when the booze is up, when the
you know, drum and bass, you know.
say I'm good-hearted, but I'm just getting started. Got my eyes on the target. No. Till the battle's won, till kingdom come. To give me your loyalty, 'cause I'm taking the world, you'll see. They'll be calling me, they'll be calling me royalty. Best to give me your loyalty, 'cause I'm taking the world, you'll see. They'll be calling me, they'll be calling me royalty. Say I'm dangerous 'cause I broke all the cages. No, I won't sit and take it. No. They left me for dead, I guess I'll never learn. Every time I break, there's just more pain to burn. They'll never learn. Till the battle's won, till kingdom come. I'll never run. Best to give me your loyalty, 'cause I'm taking the world, you'll see. They'll be calling me, they'll be calling me royalty. Best to give me your loyalty, 'cause I'm taking the world, you'll see. They'll be calling me, they'll be calling me royalty. They'll be calling me royalty. You keep chasing stars, lost in illusions, dreams and confusion. You keep chasing stars, keep falling faster, straight for disaster. Chasing
tools are crowded, freeze a party coming, move around like fresh brush when the school is out, when the booze is up, when the sun is down. Enjoy the ride, get some pillows in the Chevy. Hey, hey, slide or die, lay low, hitting heavy. Hey, hey, take your time, let me know when you're ready. Hey, hey, couple months I've been messing with the steady. Tonight, lost in the afterglow. Oh, girl, your love for me keeps calling me, so I'm calling you. Love, give me love to find. I long for your company. Oh, girl, your love for me is a part of me, my biology. Yeah, 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 over till the fat lady sings. I owe you a trip, cause me and you, we got a thing. My sunshine state, hair curly like a string. Just a big ol' ooh, smile, that's about all you gotta bring. So, enjoy the ride, got some pillows in the Chevy. Hey, hey, slide or die, lay low, hitting heavy. Hey, hey, take your time, let me know when you're ready. Hey, couple months I've been messing with this steady.
दामी बस्ती सुत्न छु टानानानाना छैन यो अब read it हैन जस्ट सुरु गर्दिउँ है ओके टुल्समा जाने कति बज्यो 12 बजेबाट सुरु गर्दिउँ टाइमर 60 मिनट्स को टाइमर गर्दिउँ क्लोज भयो ठीक हो